I'm Dr. Aimee, and today we're diving into a topic that deserves much more attention: adenomyosis. If you've ever been told that you have just bad periods or you're struggling with infertility without clear answers, this episode is for you. Adenomyosis affects up to 1 in 10 women, yet it's often overlooked and misdiagnosed, despite its significant impact on fertility, miscarriage risk, and overall uterine health. The title of today's show is It's Not Just Bad Periods: What You Need to Know About Adenomyosis and Fertility. Welcome to the Egg Whisperer Show. Joining me today is a true expert in this field, Dr. Armando Hernandez-Rey. He's a board-certified reproductive endocrinologist and the founder of Conceptions, Florida. As one of only 2 fertility specialists in Miami offering robotic surgery, he specializes in treating complex reproductive health conditions like endometriosis, recurrent pregnancy loss, and of course, adenomyosis. Dr. Hernandez-Rey, welcome to the show.
Thank you, Amy. It's great to be here.
So let's dive into the question. So you're known for being at the forefront of fertility care, including the use of robotic surgery. What inspired you to pursue this specialized path, and how has it shaped your approach to treating conditions like adenomyosis?
So I went to medical school to be an orthopedic surgeon, interestingly enough, and meandered over to the world of OBGYN, thinking that I was going to be a GYN oncologist, and just fell in love with the whole subspecialty of infertility, reproductive endocrinology, and always had a particular interest for the surgical route. I immediately fell in love with the tubal reanastomosis and the delicate sort of surgery, microsurgery. And I think that was my first interests where my interest began with infertility. And then it's not hard to just fall in love with the specialty. It's so rewarding, it's so cutting edge, technologically driven. And here I am.
I want to talk a little bit more about adenomyosis and endometriosis, and they're often discussed together, but they're very different. Can you break down what adenomyosis is and how it's different from endometriosis, and why this distinction is so important for both diagnosis and treatment?
Sure. So endometriosis is basically a disease process. The tissue that women expulse every month with their menses makes its way retrograde through the fallopian tubes and implants in different areas, causing a significant amount of inflammation. There's multiple theories, as you know, as to the genesis of endometriosis. The one that's most prevailing or makes the most sense is that is in fact that retrograde expulsion. Now, we interestingly enough, we know that happens in all women, but there are just some women that are more susceptible than others. And a essentially a dysfunction at the level of the endometrium that somehow initiates through the fallopian tubes. I think nobody really knows for sure, but essentially that's what it means. And over time, it's essentially increasing the level of the inflammatory response in the pelvis. There's multiple organ systems there. The juxtaposition between tube and ovary is extremely important. The infiltration into the ovary itself, as it makes its way in the form of an endometrioma, destroys the essential matrix of the egg and its capacity for ovulation, fertilization, and then not to mention the quality of life aspects that are significantly impacted in a majority of women, not all women, but in a majority of women who suffer from endometriosis. And really the symptoms are don't necessarily, as we all know, do not necessarily correlate with the extent of disease, as we can have stage 4 endometriosis that is goes relatively asymptomatic, and the stage 1 that is doubled over in the fetal position for 3 to 5 days, if not longer, throughout the cycle. Um, what we know about endometriosis and adenomyosis and why it's spoken about often in the same sentences is because these are disease processes, whether related or not related, that evolve over time. It's very odd, although not impossible, as to see somebody with adenomyosis in the early stages of their reproductive lifespan, and yet much more common to see it at the later stages, which is one of the reasons, and I'm sure we'll talk about why we're seeing it so often now. With adenomyosis, to go a little bit further and to answer your question fully and separate it out from endometriosis, adenomyosis is basically the infiltration of that same endometrial tissue, or that penetration, invagination of that tissue into the muscle of the uterus. It creates a bulky uterus, dysregulates the normal menstrual flow, causing irregular bleeding, painful bleeding. Also, as it expands and becomes bigger, causes the symptom complex that are associated with painful sex, chronic pelvic pain, and like we said. dysmenorrhea or painful periods as well.
Yeah, and it's not that uncommon, but why is it so frequently undiagnosed?
The gold standard is MRI because that gives us an opportunity to examine the junctional zone, which can't otherwise be visualized with transvaginal ultrasonography, number one. Certainly, it is to the seasoned clinician when you see an advanced case of adenomyosis, you only have to just put the probe in and take a look, and you'll know that there is some degree of adenomyosis. It presents in many different ways, but you see an enlarged uterus, enlarged volume, uterine volume, and classic appearance, the ground glass appearance within the matrix of the myometrium itself. And sometimes you can see some glandular tissue, which is sometimes difficult to differentiate between a degenerated myoma versus an adenomyotic glands within the myometrium itself.
Yeah. And what's so frustrating for me, and I'm sure you get these cases too, patients have gone through years of treatment, many failed transfers, and their doctors aren't recognizing the impact that adenomyosis has. So let's talk a little bit about that. What are the impacts that adenomyosis has on implantation and pregnancy outcomes?
The environment within the endometrium that is absolutely critical for implantation to occur. You see a complete absence or increase in MMP1 and 2, matrix metalloproteinases that are essential for implantation to occur. You see an increase in cytokines, which creates an inflammatory response. You see a picture of chronic endometritis, which is not an infection, but an inflammatory response that occurs. And that completely distorts the capacity for the nidation of the embryo to make its way into the first layers of the endometrium and begin the trophoblastic or the placentation that needs to occur for implantation and growth.
Great. So, for those who are listening, if you've received this diagnosis and your doctor is saying it's no big deal and it doesn't impact pregnancy or implantation, that's just not true.
Absolutely. The reason why this is at the forefront of our discussions now is because it's having a significant impact on implantation. And we're seeing older women who have certain risk factors, whether it's multiple losses that required instrumentation, endometriosis, fibroid surgeries, etc. These are all known factors that are associated with adenomyosis. As we know, women are waiting longer. Sometimes women have to consider the option of egg donation, and so we know that the components of a pregnancy, not to simplify it, but for our audiences, egg, sperm, and embryo. So that's one unit. The external environment, whether it's because of its obesity, diabetes, or some underlying comorbidities, and then finally the uterus. And you're presenting the best case scenario to these patients, a young, healthy woman who unfortunately is at the end of her reproductive lifespan and needs to go to egg donation. And you're thinking the best case scenario. And then when you have the additional obstacle to deal, which is the adenomyosis, it's very hard for these women to really wrap your mind around this. I've gone this far to do egg donation, and now I can't even carry a pregnancy. Very difficult, and certainly one of the challenges that us infertility specialists face in today's world.
And you mentioned when you do an ultrasound, you can tell if someone has adeno. So, in
Absolutely.
those patients, do you tend to still get an MRI? Do you find that to be useful, or do you feel like
I
ultrasound's enough for you?
Absolutely. I think it's very helpful to measure what's the extent of the adenomyosis. You can glean from the volume and the overall appearance of what it looks like, but I think it's important to measure the junctional zone. And if you're going to if you're going to treat it, whether it be hormonal therapy or surgical therapy, you want to have a starting point, a baseline to know whether you're improving or staying the same or getting worse, God forbid.
Yeah. Well, let's talk about that. Let's talk about how you approach treatment. And does the amount of adenomyosis impact the type of recommendations you make for a patient? And I'm sure you get this question a lot. What about surgery? Can't I just do surgery for it?
It's a very complex question and one that I'm not sure that we have all the answers for. But traditionally, back when you and I were fellows, we always just had Lupron as the to treat
I call
adenomyosis.
it, just so you know, I call it devil Lupron.
It is
Devil
devil's
Lupron. Yeah. Yeah. Yeah.
absolutely. It makes sense. You're suppressing the hypothalamic pituitary ovarian axis, decreasing the production of ovarian produced steroids or estrogen, essentially, and progesterone, which is, by the way, how we treated endometriosis back in the day as well. In addition to surgery, we many, many times the post-op treatment was Lupron. And so by suppressing this hormonal milieu, we're in theory reducing the stimulation to the uterus, to the lining, the endometrium, and hopefully reducing the volume in such a way. But I don't know that we have necessarily any way to like necessarily gauging beyond just decrease in volume of the uterus, if it's really having an effect in receptivity or anything else. Although, as you put a patient post-treatment with hormonal therapy, whether it's Lupron or today I use Orilissa or an antagonist, a GnRH antagonist instead of a GnRH agonist like Lupron is, um, we can see how well the patients do in terms of lining development, endometrial development, the characteristics of the endometrium, whether it's a trilaminar appearance or homogeneous during the when you start the progesterone, the thickness of the lining itself is also extremely important. So we're just playing detective here. We're trying to glean as much information as we can, which is why adenomyosis has become so important because as practitioners, we really take pride in what we do. We want to be able to offer the best possible success rates for our patients. And when you've eliminated the egg in like the cases that I mentioned with, or sperm, and the cases that I mentioned, you want to be able to do something as far as addressing the uterine component, which is just as important as all the others.
Yeah, and I'm glad you brought that up because I think so many patients don't know that they can advocate for themselves and say things like, "Can you check the uterine volume? See how it's changed over time." And that's something that I do as well. So when I make a plan with the patient who has adeno, and I also prefer Orlissa because it's out of the system faster, and I can also adjust
Right.
the dose if they don't feel well on it, you can measure the volume. And sometimes I bring them every 30 days, sometimes at the 2 month mark, and sometimes I extend the treatment beyond 2 months, which I'm sure you do too for some cases. But I think that's important to point out for our listeners that doctors like us, we are the detectives. We want to investigate. We want to make sure we're doing the very best for our patients. So I'm so glad you said that. So other people know that it's okay to ask for that if your doctor is not offering you that.
Absolutely.
Getting a
You should
uterine
always
volume.
advocate for yourself.
Yeah, getting a uterine volume checked, it's really easy. It's just a basic pelvic ultrasound, something that we can do in our sleep for you.
Yeah, that's right.
So I've been getting a lot of patients messaging me about ultrasound guided focal destruction of adenomyosis tissue. This is an emerging therapy using radiofrequency and microwave ablation, and it's referred to as I don't even adenoduo. Is that the right way of
I,
adenduo? Not sure if I'm saying that right. Do you have any experience with this approach and know how it compares to traditional approaches?
I do have experience with this approach. This is a new term that they've put together. I have used this before. I've used this modality, this technology before in the way of a treatment or a technique with it's called Accessa. It's a device that's owned by Hologic, and it's basically which is laparoscopic. There's also the opportunity to do it hysteroscopic radiofrequency ablation as well, which I actually like very much. I've done 18 cases of radiofrequency ablation, certainly not the 131 that are were used in that trial that recently came out. I think I've read the trial, I've read the results, and they're certainly very promising. You're talking about two very good surgeons who are leading the charge. I find the difficulties or the limitations are that it depends on the stage, like everything else. You want to treat stage one cancer before you want to treat stage four cancer. So there has to be early intervention. And I have last ditch efforts, to be honest with you, before having to move on to surrogacy. The majority of the patients that I've treated with the Accessa device or the radio frequency ablation are the stage threes, the stage fours, very advanced, very large, greater than 200 cc uteruses that have come to me perhaps for a second opinion because they've failed multiple embryo transfers at an outside facility. And then now we're stuck here trying to figure out what to do. And like ovarian cancer and the way we treat endometriosis, and I think we just alluded to it, you do the debulking essentially of the endometriosis. And then instead of chemo, you're using the Lupron as we used to do before. Or maybe the Orilissa, which we know in women who are trying to conceive, we should try to stay away from that. And surgery doesn't necessarily add any benefit to fertility, but it certainly can have a significant impact or a one-two punch, that one-two punch I just mentioned in terms of quality of life. And with the adenomyosis, minimally invasive or being conservative is best. And certainly the treatment with surgery when all else fails is can be a consideration. And certainly because it's laparoscopic and we see oftentimes the combination of endometriosis and adenomyosis, Sure, we do that too. It sometimes there's so many adhesions that even to do the radio frequency ablation, we have to take down adhesions. We have to take down the endometriosis in order to be able to get access to the bulk of the adenomyosis or the fibroids, which is how this therapy began first, which is what to radio frequency ablate or reduce the volume of fibroids in order to reduce the volume of the uterus itself and decrease symptoms.
Yeah. And in the patients that you've seen with a uterus that large who've done this treatment, have they been able to go on to have a healthy full term pregnancy?
In our group of patients, probably we have uh, it was 18 patients that I've operated on. Not necessarily all of them were for fertility. Of the 14 that came to us, we have six that are pregnant, or six that have gotten pregnant, uh, four that delivered all via C-section, no vaginal deliveries, one that had a miscarriage, and one that is an ongoing pregnancy in the second trimester.
I think those are really good statistics. For those who are listening, we'll make sure to have Dr. Hernandez-Rey's information in our show notes so that you can reach out to him for a consultation for this procedure. Because I think there are so many doctors out there that discourage patients from seeking this kind of therapy because they're nervous about what it means for pregnancy. But it's really nice to hear that you have had this experience that seems really positive and promising. So, for patients experiencing unexplained failed embryo transfers or recurrent pregnancy loss who suspect adenomyosis, how can they best advocate for themselves when seeking help from a specialist?
Ask questions. Definitely ask questions. I think that it's important to be well informed. I think when patients say, "Oh, I'm so sorry, I looked at Google." It's important to have a framework to have begin the discussion when this is something you don't do for a living. Just to have like a just some information to discuss, I think is important. And you have to be an advocate for yourself. And we as physicians not get mired in the busyness of every patient. This is not cookie cutter medicine, and you have to address every patient individually. And as women age, things are getting more complex when we thought they were going to get simpler. And then unfortunately, that's not the case.
Yeah, those are all great tips. And I think it's also important to ask the right person questions because sometimes patients they seek out the opinion of their OBGYN who's very well intentioned, but that doctor doesn't necessarily refer them to someone who's an expert like you. So if you're going to someone who isn't used to making the diagnosis and isn't experienced in helping women get pregnant with adenomyosis, they might not be the best person to ask because they might say that you don't have it when you actually may have it. Where can listeners learn more about your work and if they'd like to connect with you and work with you?
The practice name is Conceptions, Florida. We have a pretty active social media presence. And now with Google Conceptions, Florida, we have two offices in South Florida. We're in Coral Gables and Merrick Park, and they can find me just going online and putting in my name.
And is there anything else you'd like to share with our audience, especially those who may be feeling overwhelmed or uncertain about their diagnosis?
I think that it's extremely important. I think you touch upon this is to be the advocate. That's very key. Adenomyosis is something that we're just starting to understand more and more because it's become more prevalent in our population. Adenomyosis has been around forever. It was just treated when women had five children and were symptomatic. The hysterectomy was the go-to route. Now these women are wanting to be pregnant, and now we're having to deal with this adenomyosis. So we're learning more. But whether it's adenomyosis, endometriosis, or any other diagnosis, please uh, do not hesitate to ask. Don't be afraid to ask the right questions. Get informed, do your research. And if you don't like what the answer is, perhaps get a second opinion.
And I'm glad you said that about hysterectomy because oftentimes I hear the OB/GYN saying things like the only way I can diagnose this is if you have a hysterectomy. And that's really not a nice thing to
That's
say
true. That's
to
true.
someone who's trying to have a baby. And that's just untrue. You can diagnose it with ultrasound and MRI. Thank you, Dr. Hernandez-Rey, for joining us and helping shed light on a condition that too often goes unrecognized. Your insights are truly invaluable, and your dedication to patient centered care is inspiring. If you found this episode helpful, please subscribe to the Egg Whisperer Show on YouTube and follow us on Spotify so you never miss a podcast episode. We have more insightful conversations coming your way to help you feel empowered and informed on your fertility journey. Until next time, I'm Dr. Aimee. Stay hopeful.